So good evening, one and all present here. I'm extending behalf of the Dr. Agarwal's Institute of Optometry a warm welcome to Dr. Biswajit, moderator for today's session. And we are welcoming the Nitisha for introducing the Dr. Biswajit sir. Over to you, Nitisha.
Yes, ma'am. A very good afternoon to all the respectives who joined us for the presentation on pediatric challenges between trauma and non-compliance. It's an honor to introduce Dr. Biswajit Mondal, Professor and Head of the Department of Optometry and Vision Science, and Principal at NSHM College of Management and Technology at Durgapur. Holding B Optum, M Optum, and a PhD in optometry, he blends strong academics with evidence based clinical practice. With rich experience in optometry education, academic administration, and hands on practice, he serves as an external and head examiner for multiple states and central universities, shaping curricula and quality standards nationwide. His research interests span optometry education, specialty contact lenses, myopia management, binocular vision, and low vision care. Besides campus leadership, Dr. Mondal runs his own clinic, which is Dr. Mondal Specialty Vision Care, Classic Eyewear at Durgapur, offering primary eye care, contact lenses, orthokeratology, myopia control lenses, binocular vision assessments, and low vision rehabilitation. A frequent speaker at the national and international conferences and a champion of professional development, he bridges clinical excellence, academic leadership, and ethical practice, driving the growth of optometry in India. We welcome you, sir. I would like to
Thank you.
extend
Thank
my
you very much.
Sir. I would like to extend my warm welcome to Ms. Jemima Hubert, Internship Head, and Ms. Ompriya Jaishankar, Internship Coordinator at Dr. Agarwal's Institute of Optometry, Chennai. I welcome today's presenter, Ms. Harshini Rajesh, pursuing her internship in Dr. Agarwal's Eye Hospital. Over to you, Harshini.
Thank you so much, Natasha.
So thank you, Harshini, for joining us. And it's a great honor and privilege to have Dr. Biswajit join us. So thank you, sir, for joining us for the session.
Thank you very much, madam, for inviting me to join this session. Thank you. Thank you very much.
Thank you, sir. Now, Harshini will be presenting, and after that, we would be very happy to hear from you, sir. Over to you, Harshini.
Okay, ma'am. Thank you, ma'am. I hope my screen is visible.
Yes, Harshini, it's visible.
Okay. All right. So today we are going to talk about a pediatric case. And when we are talking about pediatric cases, we know that they have their own complications. So let's see this case and unravel it together, right? So now, the first thing we see over here is we had a 12-year-old male who reported to the hospital in April 2025. Okay, that is almost 1 year ago from now. Their first chief complaints when they entered the hospital, they told us they were having redness, itching, swelling in both eyes since like 1 week. And then they had no past ocular history, along with no general history. Family history was non-contributory to our case, and there was no recent investigations and no medications taken by the patient. Okay. As I told, let's unravel it together. So we'll go step by step. The first thing we see over here is that they reported with redness, itching, and swelling. So anybody who comes up with redness, itching, watering, swelling, what do we mostly say? Conjunctivitis, right? Any kind of conjunctivitis. But we do see that there was no other medication history. Let's go forward now. Now, later, during the vision checkup, it was noticed that the patient had very diminished vision in the right eye. Now, vision is all right. It's just a normal pediatric case, is what we thought. But as we are moving forward, we see that the patient is undergoing diminution of vision in right eye. Left eye was totally fine. So what comes up to our mind? We're like, why does this happen? Maybe something happened to the eye. Did something hit the eye? Something happened. So upon inquiry from the patient while during the vision checkup and everything, we found out that the patient had a history of fall on the ground 8 years back. This was revealed later. That is what we see over here. Because first, when we asked about it, they did not mention anything. But later, when we found out that yes, the patient's vision was going down, and then we asked them, then they revealed it to us saying that, oh, they had a fall like 8 years back. We know that the patient is 12 years old now. So 8 years ago means when the patient was almost 3 or 4 years old, right? That means a very small child, and any kind of these falls, hitting the head, these go very unnoticed because we know that the children are very clumsy. So it happens a lot. But one main thing which was noticed is that the parents are unaware of the long-standing vision loss in the right eye. Visual assessment was done. In that we found the diminished vision was there, right? That is, right eye had only perception of light with a doubt if the patient was able to see hand movement or not. Left eye had 612 parts vision with N6 without any correction. This is, we are talking about UCVA. And when we see that patient is undergoing like any kind of perception of light vision and all, we make sure that we check retinoglow, because retinoglow shows us a lot. If there is a red reflex, there's a white reflex, we see leukocoria. It is very important to notice the glow in retina. So in left eye, we saw that it was a normal retinoglow. It was present, whereas right eye showed no retinoglow. Of course, refraction was not performed because there was infection for the patient. EOM was normal, cover test, IOP were all not taken. In pupillary examination, we saw that left eye is normal, pearl eye is present, normal shape pupil, but the right eye was irregular. It showed sluggish reaction to light. And we saw that the patient had seclusia pupillae present. Now, this reveals the fact that why the patient had only perception of light, right? Because they had seclusia pupillae. Seclusia pupillae is basically the adhesion of the iris to the anterior surface of the lens, known as the synapse. As you can see over here, this is what happens. It also forms a ring synapse. You can see that is seclusia pupillae. The iris sticks to the lens. This is how it looks under a slit lamp. Moving forward, there was anti-segment examination done where left eye was within normal limits, but right eye, we had conjunctival congestion. As we saw, the patient did report for redness and iris was within normal limits. Lens showed complicated cataract of P4 grading, that is posterior capsular grade 4. Now, they did have a trauma that we saw that they had a fall on the ground. That may have led to the cataract, maybe complicated cataract, traumatic cataract. Let's see that, right? And next, we also noticed that iris pigments were present on the anterior lens capsule. Now, once you see pigments, iris pigments, one main thing we normally diagnose, like let's talk about differential diagnosis while unraveling it, right? So one main thing we see is anterior uveitis. So that was also a doubt which we had. Posterior examination, left eye was all good. Fundus was within normal limits. Right eye, we saw that there was congestion. There was seclusia pupillae. There was cataract. One more thing had it. Fundus had retinal detachment suspect. Now, normal, when we talk about retinal detachment, one of the main things, of course, retina evaluation, fundus, OCT will be done. One of the main thing that needs to be done to confirm it is B scan. B scan was performed and retinal detachment was confirmed. Fundus OCT was also done. Also, we noticed that the patient had cataract, right? So we were also planning for cataract surgery to implant an IOL. So A scan, IOL master, specula was done and RAM was advised. RAM to see, basically RAM is retinal acuity meter. It is used to see how much vision improvement a patient might have after the cataract surgery. So this is the fundus report. As you can see, the left eye over here is completely clear. There is no haziness in the media. On the contrary, when you see the right eye, there is hazy media. One main thing which may cause hazy media, there is shadows. What does that mean? Patient had cataract, so that causes hazy media. Along with that, we also see there is red spots over here. The red spots may be due to blood leakage, any kind of hemorrhage is present in the vitreous that may have been caused because of the retinal detachment. This is our OCT. We see that we have a view of the left eye, but right eye we have no view because there was haziness in the media, right? And also you can see that the RNFL is also good. It's 79 UM, right? Later, now main comes the part, the B scan. Over here, you can clearly see the left eye is normal. You see the clear media. There is no obstructions in between. Jump to the right eye, you see detachment. There is a detaching layer as you can see in this side. So finally, the diagnosis which was mainly given for us was there was unspecified retinal detachment with a retinal break for the right eye. And there was also complicated that we already saw, right? There was a traumatic cataract in the right eye. Along with that, secondary anterior uveitis changes was also suspected. In the next follow-up, the main thing we had to do was see that the patient's infection is cured, and then we suggest the patient for a retina specialist. Diffraction was done. Left eye had a 6/9 plus 2 and N6 improvement with the given power, and right eye only showed HM positive. So, with the confirmation with the retina specialist, we planned the surgery, which included the cataract extraction, IOL implantation, vitrectomy, SOI, and also RD surgery. The risk of RD surgery under oils and multiple surgeries have to be performed was explained to the patient beforehand. This is the B scan of the patient just before the surgery was done. You can clearly see this is taken in all angles, up, down, left, right. You can see the clear detachment of the retina over here in all the photo. Later. Now, you see, okay, detachment is there. We are doing surgery. Cataract surgery will be done. Everything is going to go good. Patient is going to have improvement, right? That's what we all think. Here comes our first complication, the intraoperative complication. The first thing that happened was there was posterior dislocation of the IOL into the vitreous cavity. IOL dropped during the vitrectomy and SOI. Most of the cases, this happens even in cataract surgeries. So it happens even in cataract surgeries. And during the cataract surgeries, we see that the IOL drop happens into the vitreous mainly because of poor capsular support. Same thing happened for this patient. There was poor capsular support, and during the VR surgery, the patient had an IOL drop. So this resulted in a phakic status of the patient. The vitrectomy and SOI was successful along with the RD surgery. Now, after the post-op, patient had a vision in the right eye of 3/60. We saw that the patient had only HM plus, right? It improved from HM plus to 3/60. That's a huge improvement. We see that the patient is improving. That's good for us. Cornea had a slight edema, which was resolving gradually with aqueous chamber being quiet. And in iris, there was inferior PI present. This was mainly done to prevent the pupillary block, as we saw that the patient also had a history of synechia. Fundus, it was status post of vitrectomy, SOI, and laser scars, along with a shallow SRF present. Normal medications were given to the patient: Senspread, Sensmos, Acunac, Imus for lubrication, Combigan mainly for IOP control as PI was done and surgery was done. And then Hyposol, Homacid was given. Homacid was mainly given to the patient to prevent synechia, as they had a history of synechia. And also, we saw that the patient had corneal edema, so Hyposol was given along with medications to reduce the inflammation and infection. This is the post-operative fundus. You can see that the media is clear. You can see laser marks over here. And at least we have a clear view of the fundus, and there is no hemorrhages present right now in the vitreous. Next, in our next follow-up, we see that the patient is having improvement, right? 3/60. From 3/60, the patient is improving now to 6/36 with +7 diopters. And a pinhole improvement was also 6/36. Slit lamp findings now showed us that they had iris pigments on the cornea. Iris pigments on the cornea are a main marker of inflammation. In iris, we saw that inferior peripheral iridectomy was done. That was now covered by a capsular membrane. Fundus was the same with vitrectomy and SOI, laser scars, and shallow SRF present. Patient was told to continue the same medication to see what will happen next. Patient has improvement. We continue the same thing. Now, because this is a pediatric case, one of the main things you have to notice is it's not just the child undergoing surgery, but also the post-operative care that has to be given for the child. The patient had 636 improvement in pinhole. We saw over here, there is 636 improvement. Drop down, direct to finger counting of the right eye. Even with +5 diopters, the patient only had improvement to 1 by 60. What may be the cause of it? One of the main things seen in slit lamp was a PED of 3 into 3 mm, which was involving the visual axis, also having positive staining. Fluorescein staining was positive for the eye. This caused the vision drop. What may be the main cause of this is infection. The patient might have undergone infection that may be due to poor hygiene after the operative procedures. So the final diagnosis over here was the persistent epithelial defect, which was present. As you can see, it involved the visual axis and it was present over here. There was strict advice given to the patient. Avoid water contact to the eye, to the right side of the face. Next, there was antibiotic cover given, nighttime protection, sense claw ointment, lubrication, and also medication to reduce the corneal edema. Okay, medication is given. We found out that the patient is having PED, right? At an early stage. Okay, we can solve it. That's what we all thought. Next follow-up, we see in the 6th, 7th, and 8th follow-up, there was no improvement. Stagnant at finger counting. The cornea still had the PED present at 2 into 1 mm. Yes, it had reduced, but then it was present. But we thought that it will have been solved by this visit. But no, it was not solved. So we thought, okay, let's place one more protection. We placed a BCL along with the same medications given. And the patient's guardians, we found out upon inquiry and speaking to the patient, like going around telling them about this, we found out that the patient's guardians were not compliant with their medications given and also maintained poor hygiene. We did see that we gave an advice to be careful, to be not putting water in the eye, but they were not compliant. This shows a main factor that compliance is very important in healing, right? Precautions were taken. We explained to the attendant, doctors explained, we who were taking visions of the patient for every follow-up, we explained to the patient's parents, their guardians that, okay, you have to be careful, otherwise improvement will not be there. And there was also a danger of early band-shaped keratopathy with a corneal scar. As you can see, it was detected. Okay, now you're scaring someone so much, you're telling, okay, if you don't do it right, your eye is gonna go, it is gonna go bad. You expect that the patient and the guardians are going to respond in a good way. They're going to be like, okay, all right, I'll be careful. And the next time they come, they're going to have some improvement. That's what we all also thought. What do we see? No improvement. Same thing, finger counting. And PSK was under danger. Now it progressed. And the cornea had a BSK present. And we thought, okay, right now the patient is with a cornea specialist. So they thought, all right, it still can be healed. We do have hope. We did EDTA chelation. And one of the best things that happened was vision improved so well. From finger counting, it went to 5 by 60. And after a 1 week follow-up of the 5 by 60, it went to 6 by 60 and pinhole improvement 624. That is the highest vision of the patient we have right now. So we had a gleam of hope into us that, okay, this patient is resolving. This is going to go good. They're going to get their vision back. The cornea epithelium was getting healed, but there was a mild haze even after the EDTA chelation. As the patient had BSK, right? We expect that mild haze. Such a good improvement. We were also happy. We were also adjusting and we were telling the patient's parents, the guardians, people who are coming, the child as well. That is the most funny part of here. We were telling the child as well. We were like, be careful with this. Don't do this. You have to be careful. You have to follow these medications. You should not touch the water to the eye. Everything was told. Now you see an improvement once you have good 6/6 vision. And if your vision drops down from that, you see the change, right? You'll be like, oh, I don't want to have blurry vision. I want to have the clear 6/6 vision. The same mindset will be there over here as well. If once the vision has improved to like 624, 660, that is with +5 diopters, the patient will have 624 vision. The patient will not be accepting anything less than that. They will be like, I had good vision. I don't want it to go down, right? Here comes the final outcome. Did they maintain it? No. Did the vision improve? No. Did it fall down? Yes, it did fall down. From 5 by 60, 6 by 60 improvement, zoop, down again to 1/60, right eye vision. Left eye vision was normal and it was stagnant throughout it all, being 6/12 parts UCVA and 6/9+2 with correction. But the right eye going up, down, all because of what? When investigated, once again, poor compliance, even with the given medication and advised hygiene, which was not followed by the parents. It was not followed by them. And you guys remember, right? We placed a BCL in the eye. The BCL was missing. Missing, not inside the eye. We think, okay, all right, maybe they rubbed the eye, it went inside, something. No, it was not in the eye. Maybe it had fallen down. They didn't even notice. Even while applying medications, it was not noticed. We placed a new BCL. What else can we do? We placed a new BCL for the patient. Cornea, again, filaments started appearing. There was corneal haze. The epithelium was healed, but there was haze, filaments, and the irregular scar. Even after this, in the 11th follow-up, all this was seen. And in the 12th follow-up, even after so many things progressing, the vision was stagnant at 1/60. No improvement. One of the main things I noticed in this when I went to the doctor myself and I asked for the suggestions, we were like, okay, what can we do? Why is this like this? Is this something that we can improve more? And the doctors themselves, they told that some cases do not have a happy ending. Some cases are meant to be like this because the child has already undergone so many things for the past 1 year time span. They have so much overwhelming feelings over this. At some point, they stop. And this is the point where we had to stop, is what they told me. This mainly demonstrates how complex and unpredictable this long-standing pediatric ocular trauma can be. Just because a case was missed out 8 years ago when the child is 3 or 4 years old, this led to something so huge and drastic. And also the fact that we need to be very careful about these pediatric trauma cases because the patient might have had a fall at 2 years old, at 1 year old, or maybe like they have hit their head somewhere around the table or they fell from the bed. It is very important to get that checked. And a simple presentation which revealed an old and undocumented injury led to a complicated cataract and retinal detachment. Although appropriate surgical and multidisciplinary care was provided, right? We do see that, okay, everything was done systematically, everything is performed, but the outcome remained delayed because the vision was already gone due to the cataract and retinal detachment, even after surgical complications, and it led to poor post-operative compliance as well. The vision of the patient did not improve. This brief phase of visual improvement was there. We saw potential for recovery. We were so excited. We were like, okay, a gleam of hope. The sun is shining towards us. And there comes the clouds and it rains. And it's all gone, all painted out. That was mainly caused because there was repeated lapses in hygiene and medication and the use, which resulted in corneal complications and literally permanent visual compromise. This case, I would like to mention, mainly highlights the successful outcomes depend not only on the timely intervention, but also and mainly on the caregiver's awareness, their compliance, and follow-up. I am not telling this in a negative tone, but it is to be mentioned as one of the things that the patient and the caregiver, their parents, were from a backward background where they were actually construction workers. This explains their awareness, their compliance, and also the lack of hygiene. No matter how much you take care, if you are in an environment where there is dust, there is all that, there are so much more chances of infections recurring, right? With this, I'd like to conclude saying that this case mainly underscores the importance of routine pediatric screening to detect the unilateral vision loss. Imagine they would have noticed it at the age of 5, that when the patient had a fall, maybe at the age of 3, and they notice at the age of 5, I feel like the prognosis of the case would have been totally different. And it also highlights the need for realistic counseling. You need to be real sometimes. You need to be real regarding the prognosis of the complex cases. You need to be ethically responsible and to prepare the families for the unfavorable outcomes as well. You cannot give false hope saying, oh, he's going to have 6/6 vision. It is not possible. You have to have the ethics to be forward, and you have to tell, okay, this is the prognosis of your case. These are the complications you're going to go through. Multidisciplinary care, yes, it is essential, but it may be limited by some social and economic barriers, as we saw in this case. And ultimately, we see that this case emphasizes that prevention, awareness, and continuity are the key pillars in pediatric ophthalmic management. Because if they had not come for the follow up, I don't think we would have noticed the PD or the RD or the cataract present, and we would be able to do all those interventions for him, right? So follow-ups are also very important. The continuity is also very important. One of the main things I like to express in this is like we saw, right? I told you that the doctors itself told, okay, all the cases are not going to have happy endings. And that is the kind of reality that we have to face while working in a medical profession. And one of the main things that left me awestruck, which was told by the guardians, the parents itself, they told it in a very like normal manner, and I was so awestruck by it. I was not able to speak anything else. They told me that what can we do more than this? He has one eye vision, right? He has the left eye vision. He can see well with that, because we suggested, okay, you can get glasses done for him so that his left eye vision can improve more. So for that, they told, what's the point of it? Simple. They were like, what's the point of it? He's able to see with the left eye. No matter if, even if his right eye is gone, it is all right. He will manage his life with the remaining vision, with the remaining left eye he has. It is all right for us, is what they told me. And I was like, in a case like that, I don't think you can convince them more saying that, oh, no, because they won't understand. Because they are set up with the mentality that, okay, this is enough. He can live his life. And I could not speak anything more to them. I was like, okay, ma'am, you can't tell anything at that point, right? So one of the main, now the last, concluding with the key points, that you need to make sure while working in a clinic, while working in a hospital, make sure about these points, that pediatric cases need a very detailed history. A small fall, a small hit on the table. Make sure you ask the parents, you dig it out from them, and you note it down. And if there is an early detection of unilateral vision loss, take it seriously, go forward with it. It can lead to, like, it may be like we saw in this case, a complicated cataract, or even if it is diminished vision, it may be amblyopia, and even that needs vision therapy and it needs to be treated. Next, we see that there's a high risk of cataract operations, IOL operations with the vitrectomy surgery. And compliance and hygiene are critical. I want you guys to preach it out, like preach it like it's your life to all the patients, that you need to be compliant, you need to maintain hygiene. Otherwise, it's going to cause complications. A simple contact lens complication can cause literal vision loss. The whole cornea can get damaged. We all know that, right? We study about it day and night about contact lenses. We know how much important hygiene is. So preach it out. And lastly, awareness gaps affect outcomes. Not only this, like not only preaching about hygiene, I would like you guys to, like, at least in your surroundings, around people around you, your family, give them awareness that, okay, this is important, this is not important, you have to take care of this, you have to do annual checkups for the, you have to do regular checkups, eye checkups. These are not just like a strategy. This is not like a, people say it's a commercial strategy. No, it is not commercial strategy. These are some things which we need to take care, and this is what will prevent the vision loss of many people and undetected problems which may be present in our eye. So, lastly, let's reflect upon ourselves, right? It was a long case. So, who do you think we truly need to blame in this case? The ignorant parents who did not notice the vision loss, the doctors who could not restore the child's vision, the ones we think as gods, or the society we live in that lacks the awareness and never let us know that this is something which is important to be done, or me, who feels sympathy for a patient whose fate seemed to be written from the very first day he walked through the hospital doors. A deep thought, right? Thank you so much.
Thank you, Harshini. Thank you for sharing a case report here. And was like a narrative and story narrative. So thank you for
Thank you,
presenting.
ma'am.
Thank you. And over to Biswajit, sir, for your valuable insights.
Yeah, this Harshini, Miss Harshini, it's a wonderful presentation, and you have
Thank you so
come.
much, sir.
Yeah, it is really wonderful listening to you. Uh, and want to I think a big round of applause you deserve, right? I think every other listeners who are listening, they must be agree with this. The way you covered the entire areas was wonderful. And to conclude this case, which highlights the complex clinical course of long-standing pediatric ocular trauma, and that remained undetected for several years. And the patient presented, which you explained, that the patient presented with mild symptoms, which was including some redness or maybe itching. And still, a detailed examination revealed a complicated cataract with retinal detachment in right eye, and most likely secondary to an old traumatic event. And even though the surgical intervention involving vitrectomy and followed by silicone oil injection, the visual outcome remained limited due to multiple factors, which include delayed presentations, intraoperative complications, and postoperative corneal complications, and which is an important lesson from this case is the critical role of early detection in pediatric eye condition. Children often adapt to unilateral vision loss, and parents may remain unaware unless routine screening or detailed eye examination is performed. And there is another factor influencing the outcome was poor post-operative complications and inadequate hygiene, so which contributed to persistent epithelial defects along with band-shaped keratopathy or eventually corneal scarring. And finally, this case emphasized that successful management of pediatric ocular disease depends not only on the surgical expertise, but also on caregiver awareness, compliance with treatment, and regular follow-ups. So with this, I'll request Dr. Jemima to add if you like now.
Thank you so much, sir, for sharing your inputs. So again, a round of applause for Harshini also, where she narrated the whole case with all enthusiasm and she gave all the details. Yes, so as she pointed out right from the beginning, careful case history is so important so that important points are not missed. So from optometry perspective, those things are required. And she said that she took a lot of efforts to teach the patient, the parents, and everything. It shows a lot of empathy. So our optometrist role does not just finish with the testing or the whatever you just treat the patient or give something to the patient, but emphasize it. Unfortunately, she and the team has done the best, but the patient was not willing to take it up. But there are many patients who I have seen that when we give reminders and regular follow-ups and telecalling, some patients do respond better and compliance is a little better. So Harshini, was there any opportunity to call the patient? Did they have any phone or something like that?
Yes, ma'am. The whole point was that we were actually, when we saw that there were complications coming up, the first thing we did was the doctor themselves, they went forward, our cornea specialists, they went forward, they gave reminders to the patient. They told that, okay, you have to be careful, this will lead to a complication. On top of that, we were seeing the notes, we saw that the patient was advised, the doctor was advising. So from my side, what I did was, I was also asking the patient whenever they came for follow-ups, and whenever we were seeing them, we were like, okay, are you following this? You need to be careful. And we were telling that, see, his vision is not improving. You need to
No,
be
what
careful
I
about
asked is,
this.
were you able to call them up? Did they have a phone? Were you able to call up and follow up?
I don't think like a tele reminder was given to them, but reminders
fine.
were given when they came to the
When they
hospital for
came, that's great.
follow-ups. Yes.
Okay, fine. All right, yeah. So yes, so you have done the best that could be done, and like generally we always like things to end on a happy note, but as you said, sometimes things don't work out. But anyway, this gives a motivation for all of us to be more vigilant in taking case history, to be more vigilant in giving instructions, to more vigilant in follow up and do the best that we can. And we have learned also a lot of things, right? So people who have joined here, I think only they can respond. The others have joined in the YouTube as well. So I would like to thank everyone. And if you have any doubts or any questions, you can feel free to ask now.
Ma'am, was the child left aphakic only, or did they furtherly did some interventions regarding the IOL placement?
Actually, no interventions was done, because when we suggested that, okay, you can go for a glued IOL, right? That's what we do mostly in the case of poor capsular support. We try for a glued IOL or a hook, right? But the parents were not interested. They were like, oh, one-time complication happened. We don't want to try anything else. And without the parents, their consent, we were
Yeah,
not
we
able to
cannot
go
go ahead.
forward. Yes.
Sadly.
So they were left aphakic for the note over here. Yes.
Okay, thank you, Harshini.
Okay, then. So if we don't, Om Priya, do you want to add anything or any questions to be asked? Any announcements?
No.
Okay, then. So with this, we'll wind up the session. So, over to Om Priya.
So thank you, Harshini, for presenting this case. And thank you, Mr. Biswajit, sir, for valuable insights. And I also thank you, ma'am. Thank you, Jamie, ma'am, for sharing their thoughts, ma'am. And thank you, everyone. And we'll wind off.
Okay, thank you everyone for joining, and thank you, Dr. Biswajit, once more for joining us. So this will be available in the YouTube as well. So anyone whom, in case your friends have missed this session, you can share it with them as well. And this is a good learning for everyone. So I would encourage everyone to check out this session once.